diabetes mellitus.
Definition.
Diabetes mellitus is a group of metabolic disorders characterized by a high blood sugar level over a prolonged period of time, characterized by polydipsia, polyphagia, and polyuria. Diabetes mellitus is a group of metabolic diseases that occurs with increased levels of glucose in the blood than normal. Diabetes mellitus most often results in defects in insulin secretion, insulin action, or even both. Epidemiology. Diabetes mellitus is now one of the most common diseases all over the world. Here are some quick facts and numbers on diabetes mellitus. Diabetes is especially prevalent in the elderly. 50% of people older than 65 years old have some degree of glucose intolerance. People who are 65 years and older account for 40% of people with diabetes. African Americans and members of other racial and ethnic groups are more likely to develop diabetes. Diabetes is the third leading cause of death from disease. Classification. Type 1 diabetes results from the pancreas's failure to produce enough insulin due to loss of beta cells. This form was previously referred to as insulin-dependent diabetes mellitus, IDDM, or juvenile diabetes. The loss of beta cells is caused by an autoimmune response. The cause of this autoimmune response is unknown. Type 2 diabetes begins with insulin resistance, a condition in which cells fail to respond to insulin properly. As the disease progresses, a lack of insulin may also develop. This form was previously referred to as non-insulin dependent diabetes mellitus, NIDM, or adult onset diabetes. The most common cause is a combination of excessive body weight and insufficient exercise. Gestational diabetes is the third main form, and occurs when pregnant women without a previous history of diabetes develop high blood sugar levels. Causes. Type 1. Type 1 diabetes is characterized by loss of the insulin-producing beta cells of the pancreatic islets, leading to insulin deficiency. This type can be further classified as immune-mediated or idiopathic. The majority of type 1 diabetes is of the immune-mediated nature, in which a T-cell-mediated autoimmune attack leads to the loss of beta cells and thus insulin. Type 1 diabetes is partly inherited, with multiple genes, including certain HLA genotypes, known to influence the risk of diabetes. In genetically susceptible people, the onset of diabetes can be triggered by one or more environmental factors, such as a viral infection or diet. Several viruses have been implicated, but to date there is no stringent evidence to support this hypothesis in humans. Among dietary factors, data suggest that gliadin, a protein present in gluten, may play a role in the development of type 1 diabetes, but the mechanism is not fully understood. Type 2. Type 2 diabetes is characterized by insulin resistance, which may be combined with relatively reduced insulin secretion. The defective responsiveness of body tissues to insulin is believed to involve the insulin receptor. Type 2 diabetes is primarily due to lifestyle factors and genetics. A number of lifestyle factors are known to be important to the development of type 2 diabetes, including obesity, defined by a body mass index of greater than 30, lack of physical activity, poor diet, stress, and urbanization. Dietary factors such as sugar-sweetened drinks is associated with an increased risk. The type of fats in the diet is also important, with saturated fat and trans fats increasing the risk and polyunsaturated and monounsaturated fat decreasing the risk. Eating white rice excessively may increase the risk of diabetes. Lack of physical activity may increase the risk of diabetes in some people. Adverse childhood experiences, ACEs, including abuse, neglect, and household difficulties, increase the likelihood of type 2 diabetes later in life by 32%, with neglect having the strongest effect. Gestational diabetes. Gestational diabetes resembles type 2 diabetes in several respects, involving a combination of relatively inadequate insulin secretion and responsiveness. It is most often diagnosed in the second or third trimester because of the increase in insulin antagonist hormone levels that occurs at this time. However, After pregnancy, approximately 5–10% of women with gestational diabetes are found to have another form of diabetes, most commonly type 2. Gestational diabetes is fully treatable, but requires careful medical supervision throughout the pregnancy. Management may include dietary changes, blood glucose monitoring, and in some cases, insulin may be required. Though it may be transient, untreated gestational diabetes can damage the health of the fetus or mother. Other types. Maturity onset diabetes of the young, MODY, is a rare autosomal dominant inherited form of diabetes, due to one of several single gene mutations causing defects in insulin production. It is significantly less common than the three main types, constituting 1–2% of all cases. The name of this disease refers to early hypotheses as to its nature. Being due to a defective gene, this disease varies in age at presentation and in severity according to the specific gene defect. Thus, there are at least 13 subtypes of MODY. People with MODY often can control it without using insulin. Comparison of type 1 and 2 diabetes. Feature: Type 1 diabetes. Type 2 diabetes. Onset: sudden. Gradual. Age at onset: mostly in children. Mostly in adults. Body size: thin or normal. Often obese. Ketoacidosis: common. Rare. Autoantibodies: usually present. Absent. Endogenous insulin: low or absent. Normal, decreased, or increased. Concordance: in identical twins: 50%, 90%. Prevalence: -10%, -90%. Pathophysiology: DM type I. Clinical manifestations.
Clinical manifestations depend on the level of the patient's hyperglycemia.
Polyuria or increased urination. Polyuria occurs because the kidneys remove excess sugar from the blood, resulting in a higher urine production. Polydipsia or increased thirst. Polydipsia is present because the body loses more water as polyuria happens, triggering an increase in the patient's thirst. Polyphagia or increased appetite. Although the patient may consume a lot of food, but glucose could not enter the cells because of insulin resistance or lack of insulin production. Fatigue and weakness. The body does not receive enough energy from the food that the patient is ingesting. Sudden vision changes. The body pulls away fluid from the eye in an attempt to compensate the loss of fluid in the blood, resulting in trouble in focusing the vision. Tingling or numbness in hands or feet. Tingling and numbness occur due to a decrease in glucose in the cells. Dry skin. Because of polyuria, the skin becomes dehydrated. Skin lesions or wounds that are slow to heal. Instead of entering the cells, glucose crowds inside blood vessels, hindering the passage of white blood cells which are needed for wound healing. Recurrent infections. Due to the high concentration of glucose, bacteria thrives easily. Assessment and diagnostic findings. Serum glucose, increase 201,000 mg/dl or more. Serum acetone, ketones strongly positive. Fatty acids, lipids, triglycerides, and cholesterol level elevated. Serum osmolality, elevated but usually less than 330 mmol. Glucagon, elevated level. Glycosylated hemoglobin, HbA1c evaluates glucose control during past 8–12 Wk with the previous 2 Wk most heavily weighted. Serum insulin, may be decreased absent, type 1, or normal to high, type 2, indicating insulin insufficiency, improper utilization, endogenous exogenous. Insulin resistance may develop secondary to formation of antibodies. Electrolytes. Sodium, may be normal, elevated, or decreased. Potassium, normal or falsely elevated, cellular shifts, then markedly decreased. phosphorus, frequently decreased. Arterial blood gases, ABGs usually reflect slow pH and decreased HCO3, metabolic acidosis, with compensatory respiratory alkalosis. CBC, HCT may be elevated, dehydration, leukocytosis suggest hemoconcentration, response to stress or infection. BUN may be normal or elevated, dehydration decreased renal perfusion. Serum amylase may be elevated, indicating acute pancreatitis as cause of DKA. Thyroid function tests, increased thyroid activity can increase blood glucose and insulin needs. Urine, positive for glucose and ketones, specific gravity and osmolality may be elevated. Cultures and sensitivities, possible UTI, respiratory or wound infections. Medical management. Here are some medical interventions that are performed to manage diabetes mellitus. Normalize insulin activity. This is the main goal of diabetes treatment, normalization of blood glucose levels to reduce the development of vascular and neuropathic complications. Intensive treatment. Intensive treatment is 3 to 4 insulin injections per day or continuous subcutaneous insulin infusion, insulin pump therapy plus frequent blood glucose monitoring and weekly contacts with diabetes educators. Exercise caution with intensive treatment. Intensive therapy must be done with caution and must be accompanied by thorough education of the patient and family and by responsible behavior of patient. Diabetes management has 5 components and involves constant assessment and modification of the treatment plan by healthcare professionals and daily adjustments in therapy by the patient.
Pharmacologic therapy.
Exogenous insulin. In type 1 diabetes, exogenous insulin must be administered for life because the body loses the ability to produce insulin. Insulin in type 2 diabetes. In type 2 diabetes, insulin may be necessary on a long-term basis to control glucose levels if meal planning and oral agents are ineffective. Self-monitoring blood glucose, SMBG. This is the cornerstone of insulin therapy because accurate monitoring is essential. Human insulin. Human insulin preparations have a shorter duration of action because the presence of animal proteins triggers an immune response that results in the binding of animal insulin. Rapid-acting insulin. Rapid-acting insulins produce a more rapid effect that is of shorter duration than regular insulin. Short-acting insulin. Short-acting insulins or regular insulin should be administered 20 to 30 minutes before a meal, either alone or in combination with a longer-acting insulin. Intermediate-acting insulin. Intermediate-acting insulins or NPH or lenti-insulin appear white and cloudy and should be administered with food around the time of the onset and peak of these insulins. The rapid-acting and short-acting insulins are expected to cover the increase in blood glucose levels after meals, immediately after the injection. Intermediate-acting insulins are expected to cover subsequent meals, and long-acting insulins provide a relatively constant level of insulin and act as a basal insulin. Approaches to insulin therapy. There are 2 general approaches to insulin therapy, conventional and intensive. Conventional regimen. Conventional regimen is a simplified regimen wherein the patient should not vary meal patterns and activity levels. Intensive regimen. Intensive regimen uses a more complex insulin regimen to achieve as much control over blood glucose levels as is safe and practical. A more complex insulin regimen allows the patient more flexibility to change the insulin doses from day to day in accordance with changes in eating and activity patterns. Methods of insulin delivery. Methods of insulin delivery include traditional subcutaneous injections, insulin pens, jet injectors, and insulin pumps. Insulin pens use small prefilled insulin cartridges that are loaded into a pen-like holder. Insulin is delivered by dialing in a dose or pushing a button for every 1 or 2 unit increment administered. Jet injectors deliver insulin through the skin under pressure in an extremely fine stream. Insulin pumps involve continuous subcutaneous insulin infusion with the use of small, externally worn devices that closely mimic the function of the pancreas. Oral antidiabetic agents may be effective for patients who have type 2 diabetes that cannot be treated by MNT and exercise alone. Oral antidiabetic agents. Oral antidiabetic agents include sulfonylureas, biguanides, alpha-glucoside A inhibitors, thiazolidinedians, and dipeptidyl peptidase 4. Half of all the patients who use oral antidiabetic agents eventually require insulin, and this is called secondary failure. Primary failure occurs when the blood glucose level remains high 1 month after initial medication use. Nutritional management. The foundations. Nutrition, meal planning, and weight control are the foundations of diabetes management. Consult a professional. A registered dietitian who understands diabetes management has the major responsibility for designing and teaching this aspect of the therapeutic plan. Healthcare team should have the knowledge. Nurses and other healthcare members of the team must be knowledgeable about nutritional therapy and supportive of patients who need to implement nutritional and lifestyle changes. Weight loss. This is the key treatment for obese patients with type 2 diabetes. How much weight to lose? A weight loss of as small as 5% to 10% of the total body weight may significantly improve blood glucose levels. Other options for diabetes management. Diet education, behavioral therapy, group support, and ongoing nutritional counseling should be encouraged. Meal planning. Criteria in meal planning. The meal plan must consider the patient's food preferences, lifestyle, usual eating times, and ethnic and cultural background. Managing hypoglycemia through meals. To help prevent hypoglycemic reactions and maintain overall blood glucose control, there should be consistency in the approximate time intervals between meals with the addition of snacks as needed. Assessment is still necessary. The patient's diet history should be thoroughly reviewed to identify his or her eating habits and lifestyle. Educate the patient. Health education should include the importance of consistent eating habits, the relationship of food and insulin, and the provision of an individualized meal plan. The nurse's role. The nurse plays an important role in communicating pertinent information to the dietitian and reinforcing the patients for better understanding. Other dietary concerns. Alcohol consumption. Patients with diabetes do not need to give up alcoholic beverages entirely, but they must be aware of the potential adverse of alcohol specific to diabetes. If a patient with diabetes consumes alcohol on an empty stomach, there is an increased likelihood of hypoglycemia. Reducing hypoglycemia. The patient must be cautioned to consume food along with alcohol. However, carbohydrate consumed with alcohol may raise blood glucose. How much alcohol intake? Moderate intake is considered to be 1 alcoholic beverage per day for women and 2 alcoholic beverages per day for men. Artificial sweeteners. Use of artificial sweeteners is acceptable, and there are 2 types of sweeteners, nutritive and non-nutritive. Types of sweeteners. Nutritive sweeteners include all of which provides calories in amounts similar to sucrose, while non-nutritive have minimal or no calories. Exercise. Exercise lowers blood glucose levels by increasing the uptake of glucose by body muscles and by improving insulin utilization. A person with diabetes should exercise at the same time and for the same amount each day or regularly. A slow, gradual increase in the exercise period is encouraged. Using a continuous glucose monitoring system. A continuous glucose monitoring system is inserted subcutaneously in the abdomen and connected to the device worn on a belt. This can be used to determine whether treatment is adequate over a 24-hour period. Blood glucose readings are analyzed after 72 hours when the data has been downloaded from the device. Testing for glycated hemoglobin. Glycated hemoglobin or glycosylated hemoglobin, HbA1c, or A1c reflects the average blood glucose levels over a period of approximately 2 to 3 months. The longer the amount of glucose in the blood remains above normal, the more glucose binds to hemoglobin and the higher the glycated hemoglobin becomes. Normal values typically range from 4% to 6% and indicate consistently near normal blood glucose concentrations. Nursing management. Nursing assessment. The nurse should assess the following for patients with diabetes mellitus. Assess the patient's history. to determine if there is presence of diabetes, assessment of history of symptoms related to the diagnosis of diabetes, results of blood glucose monitoring, adherence to prescribed dietary, pharmacologic, and exercise regimen, the patient's lifestyle, cultural, psychosocial, and economic factors, and effects of diabetes on functional status should be performed. Assess physical condition. Assess the patient's blood pressure while sitting and standing to detect orthostatic changes. Assess the body mass index and visual acuity of the patient. Perform examination of foot, skin, nervous system and mouth. Laboratory examinations. HbA1c, fasting blood glucose, lipid profile, microalbuminuria test, serum creatinine level, urinalysis, and ECG must be requested and performed. Diagnosis. The following are diagnoses observed from a patient with diabetes mellitus. Risk for unstable blood glucose level related to insulin resistance, impaired insulin secretion, and destruction of beta cells. Risk for infection related to delayed healing of open wounds. Deficient knowledge related to unfamiliarity with information, lack of recall, or misinterpretation. Risk for disturbed sensory perception related to endogenous chemical alterations. Impaired skin integrity related to delayed wound healing. Ineffective peripheral tissue perfusion related to too much glucose in the bloodstream. Planning and goals. Achievement of goals is necessary to evaluate the effectiveness of the therapy. Acknowledge factors that lead to unstable blood glucose. Maintain glucose in satisfactory range. Verbalize plan for modifying factors to prevent or minimize shifts in glucose levels. Achieve timely wound healing. Identify interventions to prevent or reduce risk for infection. Regain or maintain the usual level of cognition. Homeostasis achieved. Causative precipitating factors corrected, controlled. Complications prevented, minimized. Disease process prognosis, self-care needs, and therapeutic regimen understood. Plan in place to meet needs after discharge. Nursing priorities. Restore fluid electrolyte and acid-base balance. Correct reverse metabolic abnormalities. Identify, assist with management of underlying cause disease process. Prevent complications. Provide information about disease process prognosis, self-care, and treatment needs. Nursing interventions. The healthcare team must establish cooperation in implementing the following interventions. Educate about home glucose monitoring. Discuss glucose monitoring at home with the patient according to individual parameters to identify and manage glucose variations. Review factors in glucose instability. Review clients' common situations that contribute to glucose instability because there are multiple factors that can play a role at any time, like missing meals, infection, or other illnesses. Encourage client to read labels. The client must choose foods described as having a low glycemic index, higher fiber, and low fat content. Discuss how clients' antidiabetic medications work. Educate client on the functions of his or her medications because there are combinations of drugs that work in different ways with different blood glucose control and side effects. Check viability of insulin. Emphasize the importance of checking expiration dates of medications, inspecting insulin for cloudiness if it is normally clear, and monitoring proper storage and preparation because these affect insulin absorbability. Review type of insulin used. Note the type of insulin to be administered together with the method of delivery and time of administration. This affects timing of effects and provides clues to potential timing of glucose instability. Check injection sites periodically. Insulin absorption can vary day to day in healthy sites and is less absorbable in lipohypertrophic tissues. Evaluation. To check if the regimen or the interventions are effective, evaluation must be done afterward. Evaluate client's knowledge on factors that lead to an unstable blood glucose level. Evaluate the client's level of blood glucose. Verbalized achievement of modifying factors that can prevent or minimize shifts in glucose level. Achieve timely wound healing. Identified interventions that can prevent or reduce risk for infection. Evaluate maintenance of the usual level of cognition. Complications. Complications associated with diabetes include heart disease, heart attack, and stroke, neuropathy, nephropathy, retinopathy and vision loss, hearing loss, foot damage such as infections and sores that don't heal, skin conditions such as bacterial and fungal infections, depression, dementia, gestational diabetes, premature birth, higher than normal weight at birth, increased risk for type 2 diabetes later in life, low blood sugar, jaundice, stillbirth.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.